evening, everybody, and thanks so much for joining us today. I'm delighted to share the topic that's been illuminating literally, and both in science and practice, and in our work AutoFX. Today, Dr. Vlahovic is going to talk about photodynamic therapy or PDT. And at OFX, we developed a light-based system for treating onychomycosis that is offer a gentle, safe, and non-invasive alternative for patients who can't or simply prefer not to take systemic antifungal medication. But today's presentation goes beyond toenails. We'll be looking at the broader potential options of PDT across wound care, dermatology, and infection management, where the combination of light and targeted chemistry or photosensitizer can make a real clinical difference. And of course, I would like to say we bring light to dark places, especially the kind where fungus likes to hide. And now I would like to introduce to our speaker, Dr. Tracey Vlahovic. I'm really delighted, Tracey, to have you today, Dr. Vlahovic. Dr. Vlahovic is a professor in Samuel Merritt University College Podiatry Medicine in Oakland, California. She has over 20 years of academic podiatry experience where she has run and taught clinical trials and involved in patient care. She was the first podiatry physician to do podiatric dermatology fellowship and has published numerous peer-reviewed articles and published several textbooks. So without further ado, the floor is yours, Dr. Vlahovic. Truly
Thank
pleasure.
you so much. Oh, it's my pleasure. Thank you for having me. I appreciate it. Let me share my screen. And okay, that should be visible to everyone. Well, good evening, everyone. Thank you so much for joining us. I'm excited to talk about this because this is something that I've been exposed to for a long time and might be a new concept in podiatric medicine. So let's dive in. So the learning objectives that I hope that we cover this evening are to understand photodynamic therapy or PDT, talk about its mechanisms of action, its applications in specifically podiatric dermatology, but it has a lot of applications otherwise, and then talk about the clinical studies and as well as the evidence that's out there and the safety that's out there. All right, sorry, my screen, you know how sometimes Zoom gets. All right, so what is photodynamic therapy? Photodynamic therapy has been around a very long time, probably over 70 years in dermatology. It was actually the first drug device combination that was ever approved by the FDA. And to be honest, it's underutilized, especially in dermatology, but it's something that it exists. So what is it? Well, you need a light source, and there's various things that can be light sources, but we need something that's a specific wavelength for the photosensitizer to have a reaction to. You need a product that is a photosensitizer. This can be a topical product, and in some cases, not in podiatry, but in some cases, it actually can be an IV medication. And of course, you need oxygen in your tissue, which by definition, your tissue is alive, you're going to have that. You need all of these elements together in various combinations to create what's called a reactive oxygen species. We know that reactive oxygen species are going to be something that are going to target inflammation as well as microbes, and it's going to oftentimes destroy microbes. This is a non-invasive therapy. Now, obviously, if you're getting an IV photosensitizer, that's one thing. But on the whole, this is a non-invasive, non-painful therapy. Again, that's been around a long time. Excuse me 1 second. So what are the chemical photosensitizers that are utilized mostly in dermatology? Well, we have ALA, which is 5-aminolevulinic acid. We have its neighbor, methylaminolevulonate, or MAL, methylene blue, which we're going to talk a lot about in this lecture, and toluidine blue. All right, so those are the big ones. There are other ones, but these are the ones that are most described. As far as light sources, we can have laser or non-laser. So laser can range from pulse dye laser or diode lasers to intense pulse light. Excuse me, if any of you have ever had some hair removal, maybe you had intense pulse light as your hair removal source. That's possible. We can also have LEDs cause as our light source, blue light, red light, and even natural sunlight, believe it or not, can be utilized in this manner. So what does this look like? Well, in the realm of nail disease, this would be having the nail disease. This would be applying the photosensitizer for a certain period of time. And as I'm going to show in the next couple slides, that's all over the place. After either you leave the photosensitizer on the tissue, or in some cases remove it, you apply the light source for a various amount of time. Then as that light source is on, you are getting those reactive oxygen species being created. Once, in most cases, when you shut the light source off, the reaction stops, the process stops. So it really needs that light to happen. Now, what's happening is that methylene blue is a photosensitizer, but the other ones like ALA and MAL are actually not necessarily photosensitizing in themselves, but they're allowing the tissue to have more reaction to light. So in certain cases, it's more about what the chemical is kind of allowing the skin to experience versus something that's truly photosensitizing. But ultimately, it's the metabolites from this process that are, again, gaining these reactive oxygen species. So these reactive oxygen species are, in the cases that we're going to talk about, going to be targeting microorganisms, but it can target tumor cells, can target inflammation, pain, all different kinds of things. So those reactive oxygen species, all of you are familiar with these already. You all know about hydrogen peroxide, superoxide, hydroxyl radicals, and even singlet oxygen. So these are doing various things to the tissue, whether they're affecting DNA or RNA, or they are able to go through lipids, meaning like a lipid bilayer, disrupt the cellular membrane or cell walls. So, these are disruptors ultimately in the tissue. So where has photodynamic therapy really been utilized in dermatology? So my first experiences with photodynamic therapy during my dermatology fellowship was with actinic keratoses and acne. So, we would do blue light therapy for acne and apply something prior to that. And then with actinic keratosis, it was often aminolevulinic acid applied topically and then applying the light after that. So those are the ones that I've seen the most, but again, can be used for superficial basal cell, even Bowen's disease, which is from squamous cell, folliculitis, which technically acne kind of is. Hidradenitis suppurativa is something that we don't see on the feet, but every time somebody says that we have a clogged sweat gland on the foot, I'm like, that doesn't actually exist. We don't have clogged sweat glands on the foot. The only thing that's actually a clogged sweat gland is hidradenitis suppurativa, and that's usually in the groin, in the armpits, in skin folds. Photoaging skin. Right? Everybody wants to look younger. Red light therapy is often used for photoaging skin. And then nails, which obviously we're going to talk about and focus on. So just to get an idea of, where it's been utilized in dermatology, acne, again, is a big place. So you apply the aminolevulinic acid, which there's a I don't want to say the brand name, but we always called it the Levulan Care Stick. So we would apply that, apply the light, like leave that on for a certain period of time, whether that's minutes or hours, depending on the situation. Maybe the patient applies it at home, maybe we apply it in the office, apply the light source, and then create that reactive oxygen species. So with acne, we're looking at targeting the sebaceous gland, which is heavily colonized with various bacteria, a form of it called P. acnes. And then, obviously destroying those bacteria and allowing the tissue to heal. So, that's what we've seen time and time again for acne, and even again for a precancerous tumor like actinic keratoses. So what about the history of photodynamic therapy in nails? So again, prior to anything I'd been exposed to with nails, I'd only thought about it with other dermatological diseases. And the first time that I saw photodynamic therapy expressed as something that could be used as a treatment for nail disease was at the World Congress of Podiatry, oh gosh, probably close to almost 20 years ago. I can't even recall anymore. 2008, 2010, something like that. So, round about 10, 15 years ago, something like that, in Rome. And so I remember being exposed to it and thinking, oh, well, this kind of makes sense, but how does this work? Like, what's the process? And so the data wasn't really robust back then, and they didn't have any papers, but they were talking about it at that meeting. So these papers kind of come around about that time. So the first one I want to illustrate was Watanabe et al., which looked at an N of 2 patients. And what they did was they applied the aminolevulinic acid for 5 hours, 5 hours before applying it before applying the light, and treated once weekly until they had visual improvement. Now, 5 hours is unreasonable for most of us, right? Like, you'd have to either count on the patient doing it at home. You're not going to bring the patient into your practice and let them sit there for 5 hours. That's a treatment room that's being wasted. So that's a bit challenging. However, this paper saw complete visual or clinical and mycological cure at 3 months in one patient and 6 months in the other. So there was no long-term follow-up, but again, it was a reasonable and interesting, intriguing result, but an N of 2. The next paper looked at 30 patients who could not take an oral antifungal, and they were all confirmed in having T. rubrum, which still to this day is the most common dermatophyte that we're going to see with onychomycosis. These patients were followed for 18 months, but they only had 3 treatments, and those 3 treatments were done at 2-week intervals. Now, I think most of us can agree, if we think about our practice, we think about whether you're using topicals or maybe laser, 3 treatments doesn't seem like a lot. To me, that seems quite minimal. However, the 13 patients that they had in this particular study did well at 1 year, but only 11 of those maintained clearance at 18 months. So to me, that immediately says we need to have either more frequent or more, and just in general treatment sessions versus than just 3. Dr. Pericini, who I can honestly tell you is one of the gods of nail dermatology, she is absolutely incredible and extremely well written, and it's just a joy to work with and hear lecture. She and her group took aminolevulinic acid with an incubation time of 3 hours, so not 5 hours anymore, but 3 hours, followed by a diode laser that delivered about 37 joules. So again, if you use lasers, and I had a laser clinic at Temple where I used to work for over 20 years. So lasers is joules over square centimeters. And that number is very dependent upon what brand you use, what tissue you are delivering the energy to. So this 37 joules is not something that you would use across the board. It's very specific to, again, what laser you're using, what brand you're using, what tissue you're going after. But that's what she used at the wavelength of 630 nanometers. Patients had no pain, which is beautiful, and no local adverse events were seen. So those of you who have used laser in your practice on nails know that there's a threshold where patients are like, no, you need to stop. They, with laser in general, you are going to get its heat, right? So we're not really sure the mechanism with just laser, but laser is going to generate a lot of heat. So the fact that this particular wavelength and fluence did not generate pain is great. These patients, and this again, this isn't something that we're seeing a huge amount of patients, but it was complete clinical and mycological cure at 2 years of follow-up. So pretty impressive. Now, taking these various beginnings in onychomycosis photodynamic therapy, Robrace and his group looked at a lot of these papers and said, okay, well, this is what I propose. I propose at least 3 photodynamic therapy sessions separated by either 1 or 2 weeks. I think you should use MAL or methylene olivulenic acid as a photosensitizing agent and red light therapy. However, what he and his group thought is that you should, especially with the nails that we see, is that there should be heavily either debridement with a burr, nail nipper, etc., or urea 40% that's used for days in advance prior to applying the light therapy. So that was his thought many years ago, and I think you'll see how this pans out over time. So these are the various papers that were looked at in this particular cohort, just saying, hey, these are the various photosensitizers we used, different, again, mostly red light at various intervals. So there's no consensus at this point on the protocol as far as which light to use, which nanometers or wavelengths to use, which photosensitizer to use, and how frequently we do it. So, this is one of the issues with photodynamic therapy. So this particular paper just came out a few months ago, and this is a good systematic review of photodynamic therapy and onychomycosis. So this looked at 18 studies. This took all the literature and boiled it down to 18 studies with over 591 participants. So that's pretty great, considering that there's not a lot of randomized controlled studies with this particular therapy, especially with nails. And they found that the diode laser was the most used, followed by LEDs and intense pulse light, or IPLs. Methylene blue was the one that was used the most, followed by ALA, or aminolevulinic acid, and MAL. So we're kind of going away from what Robrace said, which was, hey, you should use MAL the most, and you should use, red light the most. Well, people were, we've gotten more sophisticated and have talked to each other and said, no, I think we should use these particular light sources and photosensitizers. Now, ultimately, across these 18 studies, it reduced what we call the onychomycosis severity index anywhere from 30 to 90%. Now, what is the onychomycosis severity index? You know it by classifying the nail as mild, moderate, or severe. So moderate onychomycosis, or OSI, is about 50% nail involvement. So reducing that OSI by 30 to 90% is pretty decent, right? Now, they did have a study that had 100% mycological cure, but they used fractional CO2 laser. My friends, if you are familiar with fractional CO2 laser, it is not something that we're going to use in podiatry. It is a dermatology product, and it's often used for skin resurfacing. We're not going to have access to that. Again, I had a laser clinic at Temple for over 20 years. I used the YAG laser. I used pulse dye laser. I would use sometimes alexandrite lasers. I never had access to fractional CO2s. I wouldn't have been able to afford renting that laser. So just as an aside. So ultimately, the clinical cure, which is clinical cure, if you take a look at any onychomycosis study, you have to be able to understand what these terms mean. And clinical cure is the visual plus the mycological cure. And that was anywhere from 20 to 80%, or I should say the complete cure is 20 to 80%, right? Patient satisfaction was high because it was painless and they're not doing anything. Because let's discuss for a second, what do we have for onychomycosis? We have topical antifungals, right, which I've done clinical trials for, oral antifungals, which I've done clinical trials for, and laser, right? So laser's our device. And laser, again, the protocols are all over the place for laser. Some patients are very motivated to use an oral antifungal, and that's what they want. Some patients prefer a topical antifungal because they don't want an oral. And some patients want laser because either it's sexy to have a laser applied to your nails, or they think, well, I don't have to think about applying anything or taking anything, right? So the patient satisfaction was high because, again, there's less pain. The patient's not doing anything at home. That makes it nice, right? The patient just comes in, you apply it, you're done. So ultimately, the takeaway from this systematic review is that it's photodynamic therapy for onychomycosis can be used as a standalone or adjunctive therapy. So if you wanted to use this with an oral antifungal or a topical antifungal, you could. It achieves high clinical success rates across various stages of infection. Of course, with most of these systematic reviews, it was mostly mild to moderate onychomycosis. It wasn't the severe stuff that we see on a daily basis in our practices. Okay, so this paper is an article that's in press. It was accepted by JATMA, which is our profession's journal. And this was taking a look at 165 great toenails in 101 patients. What is really cool about this study is that they went for broke. They were just like, okay, every toenail study, including the topical antifungal studies and oral antifungal studies that I've done personally as a PI, have been always up like moderate, like mild to moderate nails. So up to 50% or sometimes 60%. They said, no, we're going to go for total dystrophic nails, but also dermatophytomas. Now, dermatophytoma might be a new term for you. It's talked about a lot in the dermatology world. What a dermatophytoma is something that you have seen, I guarantee you, every day of your practice if you treat nail disease. Dermatophytomas are those yellow streaks, sometimes white, sometimes other colors, but often those yellow streaks that we see in the nail. We have a kind of an amorphous definition of them. I think that's something that some of us are trying to work on, really defining what a dermatophytoma is. But loosely described, it is a mass of hyphae. So it's a mass of dermatophyte hyphae. And classically has been described as something that's challenging to treat. It has been shown in the literature to be treated by oral antifungals. Most recently, there's a topical antifungal that showed success with it. But again, people don't study these in clinical trials. These are excluded. And as someone who's done a lot of onychomycosis studies in my career, dermatophytomas are excluded. It's exclusion criteria, and total nail dystrophy is excluded. So props to this study for including the people that are real life that we see normally. This was, the red light was applied for either 12 to 15 minutes, but prior to that, the photosensitizer is a liquid combination of methyl ionium chloride and a plant-based extract that was applied for 5 minutes to, however amount of time. So way better than those other studies that I talked about that were 3 hours or 5 hours, which is just not reasonable for us or our patients. This looked at these patients and applied this therapy every 2 weeks for 6 months. And they defined their success in this study at greater than or equal to 3 millimeters of growth from the proximal nail fold, or complete clearance, total clearance of the nail, right? So, I think that's reasonable because, when we do FDA clinical trials, and we're trying to get a totally clear nail, that can be very challenging to get within 52 weeks. So looking at the growth of the nail is a good thing because it's showing promise. Sometimes nails can be on the slow side in how they are progressing. And this was at 6 months, right? So that they were looking at this parameter. How were they doing in 6 months? Now, of those 165 nails, 120 of those had that greater than or equal to 3 millimeters of growth or total clearance. And 88 out of those 165 nails had total clearance at 6 months. Now, not all of them were able to have mycological studies, and part of that was because this study was done at the time, like at the brink of COVID. And so there were some patients that they had to visually say this is onychomycosis. So those of us like myself who were in the midst of clinical trials during COVID know absolutely how challenging it was. Um, yeah, those are like the dark times, right? So this study became victim to part of that, where they're just like, okay, what do we do next? How do we pivot, right? So 127 of those patients actually they were able to get studies for mycological cure, and 75 out of those 127, so it's 59%, achieved mycological cure. Now, what was interesting about this study was that there were different protocols at different sites, and they had nails that were dermatophytomas. They looked at those. They looked at, again, the total nail dystrophy of onychomycosis, and saw that the patients who had the more severe presentation were the ones who did the best. That is not usual, especially in clinical trials. And they attributed that to the heavy debridement that was being done for these patients. So they were doing, whatever podiatric physician or clinician who was, part of that study was the PI, because I was not a PI in this, so I want to make that clear. The people who were the ones who were doing the nail debridement, and attributed again that success to that heavy nail debridement, because ultimately what's happening is with a topical, you're hoping it penetrates into the nail bed where the fungal disease is. Orals, you're hoping that systemically it gets to the nail bed where the nail disease is. Well, with light therapy, you have to think, okay, I need that photosensitizer is going to make the tissue more susceptible to light therapy, right? But with nails, you've got to make it so that the nail plate is thinner. So again, those reactive oxygen species can form in the nail bed where the actual disease is. So that's why the importance of debridement makes sense for this study. And we don't typically do a lot of nail debridement for other clinical trials, but for this, it makes sense because of the mechanism of action of what's happening here. So as you can see, that's an example of the light therapy, that the box that they used. So you could insert the whole foot in there. So other nails could be treated besides the great toenail, but it's very common that we just treat the great toenails in these clinical trials. So these are some examples of patients in this study. So this is the TOEFX study. So again, we have baseline, what these patients look like, and at 6 months. So again, remember, they were looking at how much growth from the proximal nail fold happened. Was it greater than or equal to 3 millimeters, or do they have total visual clearance? So for instance, with the dermatophytomas, you can classify something like this as like that yellow or white cloud that we'll see in nails. That's our dermatophytoma. So those, again, traditionally are challenging to treat. And you can see patients going again from baseline to 6 months, and how much nail growth they had, how much nail changes they had, and what their result was. So this is something that, and you can even see the staining from the blue, from the photosensitizer. That's not nail polish. That's from the product itself. So ultimately, I think those are really lovely results, showing both the efficacy of this, but also the safety of this. So we talked about onychomycosis, and I think most of us are saying this is something that we can utilize in our practices for patients who probably failed some other therapy. And that's one thing that they looked at, that in that study in Press, was how many of these patients had failed previous therapy? Well, the majority of them had, right? So it makes sense that we can offer something else to them. And maybe, again, there's a lot of patients who don't want pharmacological therapy. It's nice to have an alternative. What about nail psoriasis? If you know me, you know I'm very passionate about psoriasis in general. So I had to add something about nail psoriasis. Now, when people ask me about how to treat nail psoriasis, there's again not a great consensus in protocol. I will inject their proximal nail folds with triamcinolone. We can use biologic therapy. Sometimes we'll use topical tazarotene, which is a retinoid. If retinoids are like what we use for acne and anti-aging. So there's a lot of different things out there, and there's not like one magic bullet with nail psoriasis. So this particular study said, okay, you know what? Let's take a look at photodynamic therapy using pulse dye laser and just pulse dye laser. So I can tell you in my own practice, what I had done was I would use tazarotene topically, I would use injection therapy, but I also would use pulse dye laser. Pulse dye laser is evidence-based medicine for nail psoriasis. It's not perfect, but it was good. And for patients of mine who did not want to go on a systemic therapy for their psoriasis or their nail psoriasis, it was a good alternative. So I've very well versed in using pulse dye laser for nail psoriasis. So what they did was they took 61 patients that were treated with photodynamic therapy, and they used MAL as the photosensitizer, which I thought was interesting. And they had it on there for 3 hours versus just patients who just had pulse dye laser. So again, the photodynamic therapy that they used was pulse dye laser, but they used MAL as the photosensitizer versus people who just had pulse dye laser. All right. So what they found was that there was actually no statistical difference between the two therapies. So that's good, right? I mean, sometimes finding that there's no difference is a good thing because that means you can go either way with a patient. And what they found with using the methylaminolevulinic, which is the MAL acid, or tazarotene, which is what I've traditionally used, did not actually change the nail score results. We call it the NAPSI scale. Didn't really change that, but a significantly higher percentage of patients had improvement after 6 months of treatment with tazarotene plus pulse dye laser than just tazarotene alone. So this makes me think about my own practice, that if I were to use pulse dye laser again for my nail psoriasis patients, I would have them apply tazarotene first and then use that almost as their photosensitizer, because retinoids are very photosensitizing. It's why we use them at nighttime and not during the day because of that. And so I would definitely consider this protocol with my own patients. Okay, so let's switch gears from nails to wounds. I'm someone who loves treating inflammatory-based wounds, but wound can become colonized. We know that within hours of a wound occurring, we're going to have Staph aureus create a biofilm, right? So we know that these can become colonized and ultimately can become infected, right? So this particular study it was a systematic review and a meta-analysis of photodynamic therapy in diabetic foot ulcers that were infected. So ultimately, from all that they found that was out in the literature, they could only boil it down to 4 studies. And what these studies looked at pretty consistently was looking at photodynamic therapy versus collagenase, systemic antibiotics, and just plain old dry sterile dressings or just boring old dressings, which, we all use, right? What they ultimately found was that photodynamic therapy in these diabetic wounds reduced microbial load, which we would expect, and increased tissue repair, which is pretty cool. We know photodynamic therapy with the reactive oxygen species are going to target microbes, but also that it's reducing inflammation, right? So it's changing the playground of that wound, not just from a microbial perspective, but also from an inflammation perspective, which is why we use certain advanced dressing therapies, to reduce the various cytokines and things that are there so that the wound has a potential to heal. So ultimately, they said that there were significant improvements in both of those, plus the clinical evolution of the ulcer. So that means the ulcer was getting smaller. The problem is that from this systematic review, that the treatments range from one treatment, which I don't understand. One treatment is not enough, up to 23 treatments, which sounds sadly more reasonable, especially, with some of the wounds that we deal with, and wavelengths all over the place. Methylene blue was the one that was used the most, which makes sense when you think about methylene blue. But what I loved about the result of this paper was it said the amputation rate was 35 times lower in the group that had photodynamic therapy in comparison with the groups that received other treatments. So I think that's a no-brainer that this could be utilized in our heavily colonized and infected patients as an adjunct. Again, this doesn't have to be a standalone therapy. This can be done in conjunction with all of the other things that we do for wounds, but it certainly is compelling. Okay, so let's talk about biofilms. We all know that biofilms, it's on us right now. It's in the plaque in my teeth. It can be if you have a catheter, it's in your catheter. It's on your heart valves if you have an artificial heart valve, right? So we have biofilms everywhere, and we know how quickly biofilms form, especially in open wounds. And traditionally, we're going to handle biofilms, whether it's with debridement with cold steel, we're going to use various chemicals, some dressings address it. We have different ways of tackling biofilms, whether it's a silver dressing or either again electromechanical methods or what have you. But we know that we have to disrupt the biofilm in most cases in order to have effective healing. So this particular study looked at methylene blue and photodynamic therapy to destroy the biofilm in a wound. And after a single light treatment, the bacterial count was decreased by at least 99.9%, which is wild, right? That's pretty great. But methylene blue alone reduces the number of bacteria by 90%. So adding that light therapy just enhanced it. It was a synergistic effect. And ultimately, that's what they found across all of these diabetic foot wound studies, was to say, you know what? This is a synergistic effect of using, excuse me, this photosensitizer, the light, to decrease bacterial bioburden, and then doing all the other things that we would do for wounds, like debridement and offloading and all of this. So it all has a synergistic effect. So a possible photodynamic therapy protocol that we could use for wounds would be using methylene blue, which again is a potent antimicrobial in itself without light, adding the light and creating that reactive oxygen species to target not only the microbes in the wound, but also inflammation. And going after the biofilms, right? Because that would be lovely if we could target it all. Debride the wound first, apply the methylene blue, and then whatever light source, probably a red light, again, 2 to 3 times per week for several weeks. Those of us who've worked in wound care centers, sometimes we only see a patient once per week. Sometimes we're able to see patients more, depending on the situation and the insurance. We've all been there, right? So it could be challenging for patients to come in that frequently, especially if there's copays or even depending on what the timeline is. But ultimately, it's something to consider. We know with the evidence-based medicine that's out there, using methylene blue and photodynamic therapy not only helps with the microbial load, but also reduces exudate, odor, and wound size with, again, minimal adverse events, which with a lot of our patients with wounds, we want to minimize the adverse events as much as possible. Again, we're going to do this in addition to good wound care, offloading, nutrition, reduction in blood sugar if they are a patient with diabetes. So all of those things go hand in hand in this. It's not just applying this and it's a magic cure. It's like, what else can we do to the environment to enhance this healing? So again, ultimately, we know that methylene blue is going to work on MRSA, and it's been shown to work on MRSA biofilms, Pseudomonas, and I can never say Acinetobacter. I always want to say Actinobacter, but I think that's wrong. It's one of those, it's really hard to say. Anyway, ultimately, this is something that could be utilized for patients. The biggest drawback with this is that the tissue is going to stain blue. We just have to warn patients ahead of time, hey, your nails might be blue, your tissue might be blue. It'll go away. It's not there to stay. Like if they have silver staining, which can be oftentimes permanent, blue is not, that blue stain is not permanent. So ultimately, the advantages to photodynamic therapy in general for skin issues, but specifically for a lot of the podiatric dermatological conditions that we treat, is that this can be a standalone therapy or an adjunctive therapy with minimal to mostly no adverse events, right? No pain, no burning, nothing like that. It's very targeted therapy. And once that light is on, things are happening. Once that light is off, the reaction shuts off. We don't see long-term side effects that are negative with this. And especially if a patient has failed previous therapy, whether that's in wound care or nail disease, this seems to be a good next step. We know that it's safe and efficacious from the years and years of literature that are out there. So certainly it's something to consider. However, we don't have a standardization in protocol across the board for any of these dermatological conditions. So this leads the way to more randomized controlled studies that need to occur. I mean, that's how we learn things, to get optimization and to see, what is the best wavelength, what is the best timing, what can the patients handle. Again, with wounds 2 to 3 times a week, that's not achievable for most patients or even wound care centers. So it's something to think about. Timing and visits for patients, again, depending on the situation with copays or if they're paying out of pocket, whatever that might be, that certainly can, depend on, change their access to things. So ultimately, this is something, again, photodynamic therapy is underutilized in dermatology. It's something that's still a very new concept in podiatric dermatology. And I think that given the way that our practices are changing and shaping, it's something that we can utilize and also embrace in podiatric dermatology and podiatric medicine. So that's it for my presentation. I am very grateful that you logged on tonight, and I hope that this was useful and that you learned something. So thanks.
Thank you very much.
Thank you.
ALA is a very interesting molecule. We also looked at that. Yes, unfortunately, as you said, it's metabolites. It's enzymatic reaction and it takes forever. Also, it's need to be kept in a refrigerator, so it's super complicated. Yeah, so.
Yeah, so it makes sense that you chose what you chose,
Right.
Yeah, I mean, nails are going to be a very different animal than an actinic keratosis. So, luckily there's a range of different products that are out there that make sense for what tissue you're targeting.
Right. Also, methylene blue is super small, and it's easily penetrates through the keratin. So, yes, but super interesting. Okay, I think we have few questions. Okay, Dr. Silverstein asked you about how many patients you have personally used the TOFX with, so you can answer. Yeah.
Well, so currently I left my practice in Philadelphia and I am starting up practice in California within the next month or so. So currently I have 0 patients on it because I've had just a brief hiatus as I've been getting my license in California. So, it's something that when I start practicing in California, that certainly I will utilize. Yeah.
Michelle asks source of methylene blue.
I'll let you answer that.
I'm not sure I understand. So, a
How do
TOFX.
you how do you get it or?
We have patented a unique formula that we use a methylene blue together with few organic solvents that stabilizes the methylene blue because it really likes to be a dimer, and we really wanted it to stay in a monomer. Monomer absorb the light much more efficiently than dimer. Also, we used organic solvents that helps to kill the fungus and the infection. And also they help to withdraw the methylene blue into the nail bed. And as Dr. Vlahovic said really nicely, we also used botanical extract that also act as a photosensitizer, but also has some antifungal and antimicrobial properties, such as the methylene blue. So I hope I answered the question. Does skin type color make a difference?
So I would say for nails, no. With wounds, I would protect the peri wound depending on what photosensitizer you're going to use. So for instance, with the peri wound is such a very important place in my world because like that's where that's the skin that's coming in, right? So we want to protect the peri wound. We'd want to use in certain cases eyewear to protect our eyes. But this is something that we could use in various skin types.
What wavelengths are optimal? Any brand name for PDT?
Well, it depends on what photosensitizer you're using. So, certain photosensitizers are going to be more receptive to various wavelengths. So it's really dependent upon what photosensitizer you're using, what product line you're using, things like that. So that determines your wavelength is what it's going to absorb best. I'm sure you can, if you want to talk about that more, but
Yeah, I can answer for TOFX. Because we decided to use methylene blue, because what I explained, it's a small molecule, it penetrates really well, it's charged, so it's adheres predominantly to the infection. And it's working very well with red light that also has the ability to penetrate deep at 616 nanometers. So it's the marriage was really good. So we combine it in a very specific wavelengths that also has the ability to penetrate very well. Does it work on onychomycosis?
well, onychogryphosis is a ram's horn nail, right? That's often due to neglect. So if that onychogryphosis were to have onychomycosis, that's one thing. But onychogryphosis is often a mechanical issue as well. So with onychogryphosis, what we're getting is retroaction where the nail plate, because of the trauma and the length of the nail, is getting it pushed back into the proximal nail fold. And then that's causing a lot of issues. So we get what's called retronychia and onychomycosis happening at the same time. And that creates that ram's horn nail look. So if there's onychomycosis related to that, that's one thing. But for onychogryphosis itself, that has no fungal infection, that is a different entity. That's a mechanical issue and also a neglect issue.
Thanks. And we have Dr. Patricia Nicholas. She's using TOFX and she would like to share her experience. She uses about 30 patients. So if anyone wants to talk to her, by all means.
Oh, that's lovely. Thank you for sharing.
In onychomycosis, did any subject have total clearance in 6 months? If so, would it simply cure or related to nail growth as in other therapies? So, yeah.
So there were patients that did have total clearance. And I would be very cautious about comparing a device next to oral and topical antifungals. The studies and the protocols are very different. It's like comparing oranges to apples. The thing that you can often compare across the studies is mycological cure, but you can't really compare other things. They're very different and they're done differently. So, it having about a 59% mycological cure is slightly above the topical therapies, and it's slightly below the oral antifungal therapy. So, it's in between the topicals and the orals as far as mycological cure. But again, visual is, or clinical cure is another thing. That's again that I would hesitate again comparing, because the protocols are so different, the mechanisms of actions are so different. I would never even want to compare orals to topicals because the protocols are completely different when we do clinical trials. But yes, to answer your question, there were patients with total clearance at 6 months.
This is Dr. Markinson. He asked you this question. Brian, yeah.
Okay.
Yeah, I wanted to ask in that perspective. So there is FDA guidance document that is used, a guidance to assess the success of onychomycosis. So one of the parameters are to look at nail growth, 3 millimeters and above after 6 months, and then mycological cure at 12 months. So this is according to the guidance document. Okay. Thank you so much.
Thanks again for having me, and thanks for everyone for logging on.
Have a good night. See you soon.
Bye-bye.
Bye-bye.